Good afternoon, everyone. My name is Shanelle, and along with Anna, who's up with me today, Rebecca, who's in the crowd, and April, who's back at work actually, holding the fort for us, who've all contributed to this project and work as part of a multidisciplinary M&D clinic at Northern Health Victoria. We would like to present our preliminary findings looking at people with ALS, M&D, and clinicians' perspectives of acceptance and use of assistive technology. Throughout this presentation, we'll be referring to assistive technology as the abbreviation AT, which refers to all types of equipment required every day for safety and mobility, home modifications, communication devices, feeding tubes, and assistive breathing equipment. Now, as clinicians, we know that assistive technology has been shown to enhance independence and quality of life with people living with MND. And in light of this, how many of us have thought at some stage or another, sometimes in frustration, if you just accept this piece of AT, this could make your life a lot easier. But in reality, it's obviously not sometimes what our clients or how our clients see things. So keeping this in mind, when having discussions with your clients around AT, we are hoping for clinicians, we can get you to start thinking about and being conscious of, one, your practice and approach when addressing AT to ensure optimal independence, access to community, dignity, safety, and improved quality of life. To have person-centred and timely discussions around intervention planning, and to understand the perspectives of people with MND towards these interventions, which will all hopefully can be used to assist clinicians with applications, future planning and advocacy work. For people with MND, their carers and loved ones, we are hoping we can get you to start thinking about how you can work with your clinicians to better achieve your goals. So we know that the needs of people with MND evolve and change as the disease progresses. And as clinicians, we need to be responsive and flexible to help meet these personal goals. We've heard a lot about the assistive technology prescription kind of journey, but as we know, a critical issue has been predicting when and what assistive technology a person with MND will require to facilitate appropriate care, early implementation of these interventions, and balancing this to ensure we meet their personal goals. Fortunately, we are now in a position where we are in possession of some great articles and tools that have allowed us to better predict the type of AT a person living with MND will require and when this AT will likely be needed based on a person's phenotype and functional rating score. However, due to extensive wait times for AT in some funding streams, these applications need to be made much earlier in the disease progression than when they're actually required. Considering the differing patterns of acceptance of AT and the fast progression of MND, the timing of prescribing AT is extremely critical. We know that the risk of delaying AT prescription and acceptance can lead to compromises to both people with MND and their carers' safety at home. So for example, from unsafe transfers, hospital admissions due to malnutrition and aspiration, social isolation from not being able to communicate effectively, and ultimately poor quality of life. So what we are aiming for is to understand factors and perspectives associated with AT, both prescription from clinicians and acceptance from people with MND, which will hopefully enable us to discuss and prescribe AT more effectively and adopt strategies to maximise acceptance and increase clinicians' confidence and sensitivity with this process. So this is an exploratory study using qualitative research methods that adopted a convenient sampling strategy. Qualitative data was collected by using two semi-structured focus groups with clinicians who were involved with prescription of AT. These were all allied health professionals working in the Northern Health Progressive Neurological Disease Clinic. Client interviews were conducted with people with MND involved in the Northern Health P&D clinic and who consented to be part of the study. Our preliminary data included 3 interviews, 2 with a lumbar onset and 1 with a bulbar phenotype. Oh, sorry about that. The information from both the focus groups and interviews were coded, analysed and grouped into major and sub-themes. So our results were merged into 3 factors, the first of which looked at factors that directly related to a person living with MND. The following word cloud shows the strongest themes in bold from the combined results of the focus groups and interviews. And we've identified that some of these factors we can change or have influence over, and obviously others that we do not. These were identified as the top 3 themes that influenced a person living with MND to either accept or decline assistive technology. If we look closer at acceptance, we've identified the sub-themes of not only the acceptance of the AT itself, but the need to accept the diagnosis. One of the participants we interviewed shared his views around the acceptance of AT, stating, and I quote, "While health professionals try to help by reassuring that there are various AT to help as a patient's condition progressed, that same AT becomes benchmarks of the same progression." The view he was hanging on to for a very long time was, if I don't need it, then my condition has not progressed. I think we can, all agree that this obviously highlights that while we as clinicians see AT as a positive way of enhancing independence, for others that very acceptance can mean the need to accept the diagnosis and highlights the progressive nature of the disease. Family was the second largest factor that influenced the acceptance of AT. So, influence of family members, how well family engaged throughout the disease progression, what were the impacts going to be on the family and their lives, family acceptance of AT, and how well they engage with clinicians. The impact on family was a strong theme highlighted by some of the clients we interviewed, with one participant commenting, and again I quote, "You are living in just an ordinary house that's not just your own, but you are changing it just for you." That she didn't want to disrupt their lives even more than it was already being disrupted. The perceived impact on family of people living with MND was highlighted as both a major barrier and an enabler to AT acceptance, with another participant highlighting that his eventual acceptance of AT was simply due to it not just being about you, it's about the people who are helping you as well. In terms of knowledge and understanding, some important things were highlighted. So knowledge and understanding of MND itself, so disease progression and likely needs. The knowledge around AT, so for example, have they seen, heard of, or known someone who's had various AT in the past, as well as their knowledge of services available, were all found to be either enablers or barriers that influence the acceptance of AT.
Okay, clinician factors. So these, similar to the people with MND, these were the strongest themes relating to clinician factors in the interviews and focus groups that were completed so far. So out of the clinician factors, these top 3 themes that influence a person living with MND to either accept or decline AT were identified. And a lot of these you'll see that actually have been talked about today by the previous presenters. So if we take a closer look at approach, we've identified these sub-themes. Clinicians identifying the right time to start the conversations and when not to, making sure after planting the seed, the clinician continues to have the discussion with the person and their family throughout the journey, being 2 steps ahead, thinking of what the person will need in the distant future or the more immediate future, as well as thinking about right now. Having a clear, concise documentation in handovers or reports for your team members or organisations for funding applications so they can understand what you're asking for. Aspects of AT are becoming more mainstream, as we've talked about today, such as Google Home or Apple Home, or just being able to go to Bunnings to get your sausage and your wireless doorbell, or to IKEA and get the breastfeeding pillow, just like everyone else on a Saturday. So talking to the person and their family about the risks of having the AT or not having the AT, allowing them to make that informed decision. As several of the clinicians that we talked to mentioned, it's about sitting with that discomfort of maybe they're not going with your recommended idea. Looking at bringing back the larger aspirational goals to something more meaningful, relatable and realistic. Then if we have a look at person-centered care, we've heard a lot about that today, and I think we get a lot of it in training as health clinicians as well, so it should be familiar to a lot of you. But what do we mean by this? So it's taking time to build rapport with people and families. This may require different approaches. It also involves respecting people's values, knowledge and roles, and the person they were before they met you, before they got the diagnosis. At the centre of person-centred care is collaborative goal setting, moving away from that impairment and AT focused goals, which I know we get training as therapists and we might think we're doing a great job, but one of the participants that we talked to liked to tell us otherwise. What he thought was an explicit focus on goals would make the patient feel a sense of agency, which M&D robs us. When I focus on goals, I see possibilities, and when I focus on AT, I see mundanities. Giving them choice and control to make an informed decision about AT, which is right on the NDIS trend. The last sub-theme in Clinician Factors is communication. So modifying your language and terminology you use, depending on age, English as a second language, which we talked about earlier, technology use or interest, health literacy. Most importantly, it's about allowing people and their families to have time to process the amount of information that they're getting and the concepts of AT that they never knew existed before. Communication is also a way to change your approach. And as a clinician that we talked to raised about, changing your approach is also about changing the definition of what independent means. So whether it is with a different piece of AT, you're still independent, and changing that throughout the diagnosis. So then we move on to other factors. Other factors is pretty much what didn't fit into the first two. So these are the strongest themes that came out of for that. So with other factors, these three were the top themes. So resources for AT, if we have a closer look at that. As we've already mentioned throughout today, it's about having access to equipment to trial, AT to trial. So whether it's an equipment library, if you're lucky enough to have an M&D service that has that, or if you've got some of your own stock there, whether you develop a relationship with a supplier who will let you keep that piece of equipment just that little bit longer without having to pay for hire, or if you've got, in Australia, an NDIS package that you've got hire built in, you could use that. Providing information about the type of AT that you're recommending so they can go away and complete their own research, come back to you when they're ready, looking at different funding options and waitlist times, and starting conversations and applications early so they can receive it when they need it. As one of our participants mentioned, in M&D world, months is a really long time. So by the time the funding comes around, maybe they don't even need to use it. It's no longer relevant to them. Or maybe when you're trying to jump the queue at the beginning and get them on top of the wait list when they're ready for it, they're not ready to have that conversation yet. Seeing other people use AT as well to get their personal perspectives instead of just the therapist saying, oh, someone I know or someone told me that this works. So the function of AT, being able to achieve those goals and also giving that person the form of agency. Then we look at multi-agency. So this is not just about your multidisciplinary team. This is about looking at everyone involved, as was highlighted earlier in presentations, such as your M&D regional advisors, neurologists, palliative care in Australia, NDIS, My Aged Care, home care packages, community home support program, families, friends, formal carers, informal carers, and also the person themselves. So it's about each person having knowledge of what their role is and what their scope is, and also what others' role and scope is as well. When someone asks a question about a particular AT or even a service, they know who to talk to about it. For example, when an OT like myself is looking at hand function, but the person might also have a PEG, is that you're not just looking at, I guess, day-to-day stuff. You're also asking about, can you open and close the PEG? Can you twist it? Are you flushing it yourself? Those sorts of things, which will reduce the time for a double-up conversation from the dietitian, or also lets me flag for Shanelle to follow up as well. Having brief information about your role with the people with M&D that you can give to others and refer to later. And the last one is working with people with M&D. Support for clinicians. So working with people with M&D and supporting them and their function and roles can be very confronting at times. It is important to seek emotional support when you need it, whether it's from a professional service or informally in your team. Being able to upskill through mentoring or joint sessions with your own discipline or another, getting support from experts in the area, whether it's by a group Facebook chat or more formally, attending any relevant courses or PDs and getting that support from your team. And very importantly, looking after yourself. Self-care is important. So what have we learnt so far? So hopefully many of these factors can affect AT prescription and acceptance. Some we can affect, some we can't. So something like the rate of progression, we can't change that. But whereas something changing your approach, we can change. Everyone is different, everyone's journey is different with AT, and you need a few things in your toolkit to bring out at any moment. Being adaptive with your communication style and your clinician approach, and having a tried and true approach will not actually work with everyone, so be adaptive. Start planting the seed early, and slowly introduce the future AT needs if someone is overwhelmed with that information. Be creative and introduce AT in a lot of different ways, whether it's on your phone, showing pictures or videos, trials, handouts, and this goes for everyone. Have an open discussion, have a talk about, do you like to just get all the information up front and then go away and do your own research? Are you a self-researcher? Is it too much? Do you just like to be told, just tell me I'll just go out and get it. Just tell me what to do and I'll do it. So have those discussions. That goes for people with M&D and their carers and also clinicians as well. To upskill for the clinicians, and as I said, emotional support. That's very important for everyone to take care of themselves. So we'll just leave you with this quote from one of our participants about his journey with M&D and AT. Thank you.
Thank you both very much for your presentation. Does anybody have any questions? Just looking for hands. Oh yes, there we go.
Thanks, that was a great talk. I'm curious to know, the literature shows that up to 35% of people with motor neuron disease have some kind of cognitive change or cognitive impairment, and that has been shown to influence treatment acceptance in some cases, and I'm just curious to know if you had any kind of measure for cognitive change in this.
In the participants that we selected, we ruled out cognitive impairment just for this initial one, for having the one-on-one. Whether it is in the future, then we might get involved with one of the carers. We actually had someone that we identified with Barba, but when we went to go and ask her, she'd now been identified to have frontotemporal dementia, so we had to exclude her. And we were actually hoping to have more interviews completed, but as things happen in the world, in life anyway, that didn't occur. But it's something that we would consider in the future.
Thank you. Any other questions? No? Okay, thank you very much, both of you.